We have a quorum. Good to see everybody. I'd like to welcome everyone and call the meeting to order. I'd like to introduce us with an opening prayer. Bobby, would you give us that honor if everybody would stand?
Our divine Heavenly Father, Lord, we thank you for this opportunity that you give us each and every day to serve the people of the state of Mississippi. Lord, I thank you that you have allowed me to be a part of this august board for the time that I've been here. Lord, we thank you as we go into this Easter season. We thank you most of all that sending your son Jesus to the cross, that through our belief in him we might have life and have it everlasting. These things I ask in Jesus' precious name. Amen.
If you would remain standing for the Pledge of Allegiance.
Flags are
Flags are outside.
We'll see it through the plug.
I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
You may be seated.
Chairman, if you allow me,
Before we get started, I would like to give the floor to Mr. Moody.
you know, I've always had a lot of questions about how did a farmer and a cotton gin from Winston County get involved in healthcare. I guess the farthest thing from my mind in 1983 was getting involved in politics. Ann and I had already gone to sleep one night. Telephone rang. The fellow I answered, the fellow said, look, there's a group of us together. We're interested in getting somebody to run for the legislature that we can support. Would you consider? And I said, look, I don't know. I've never thought about this. Give us a chance to think about it. Well, we have a special needs son, and Ann had really fought the school system, trying to get special education to a point where my son didn't just bring home a colored picture each night, but came home something that would help him to develop into what he could possibly be. And that's, we decided to do that. Well, I won. Tonight, after they counted the votes, they were still counting them by hand. A couple of the fellows that I had known in the legislature called me and said, look, you need to come in with the speaker tomorrow. I said, well, hadn't we got to elect a new speaker? I said, yeah, but that's what we need to do. So I came down and met with the speaker then, Buddy Newman. And he said, Scallenberger, he said, I've heard about you. He said, what are you interested in? I said, well, like everybody else, I'd like to be a member of one of the major money committees. He said, well, I can probably accommodate you, but he said, I need somebody to get involved in public health who is really willing to work and devote their energies to that. And I said, well, you know, if that's where you want me to be, I'll do it. He said, well, he did appoint me to Ways and Means, one of the only freshmen that was appointed to that committee. But he also sentenced me to public health and welfare. In that time, really, that was what it was considered. You were appointed to most committees and sentenced to public health. Not only did he do that, but he appointed me to a committee of 5 that was to go out to Whitfield and determine what their need was out there and how we could make them Medicaid eligible. And we went every Monday. We came in early and went every Monday. And I can tell you right now, I dreaded having to go out there. But I committed then that if I couldn't make a difference, then I was in the wrong place. And thankfully, we were able to make some significant improvements out there. They had a feeding system that was built in 1907. Some of the meals that they were serving had to be warmed for the 3rd time before they were given to the patient. We were able to build a new up-to-date cafeteria out there. We were able to build a mental health facility in Tupelo and one in South Mississippi below Hattiesburg. In the early, I guess the late 70s, in the late 80s, I've heard about a program in Massachusetts where they were taking individuals who were handicapped and putting a job coach with them. And I went up there and stayed about almost a whole week with them learning about that program. We were able to bring that program back to Mississippi. And the Department of Rehab Services asked my wife if she would come and try to help them get that started. That's where we can take an individual who is handicapped, put a job coach with them for up to 6 months to teach them how to do a specific job. And she had never worked out of the home. She had done some substitute school teaching, but she agreed to do that. I went in my closet several times to look for something that I wanted to wear. And I'd say, "Ann, where is so-and-so?" She said, "Well, I had a client that was going through an interview and they didn't have exactly what they needed to wear." So that was where my clothes went. Anyway, I think about some of the things that I'm most proud of about being part of. That's one of them. Another one is our group home sheltered workshop situations around the state. I don't know if any of you are familiar with the mustard seed here, but we were charter members of that. And our son was actually the first resident out there. And that's what our group home sheltered workshop are fashioned after. When I left the legislature, there were 52 either completed or on the drawing board to be completed. I just think of some of the things that I was actually fortunate to be a part of. Jim them had me over at Medicaid when Katrina came through. And I can assure you that the 4 months of trying to put it back together was probably the worst part of my life. But I think Jim will tell you right now, they probably had less problems with Medicaid than any state agency that they had.
That's true.
At the end of that, we were able to put together a program with HHS that sent $75 million to Mississippi to pay for uncompensated care, and the state didn't have to put up $1 for that. But I guess my service here for 10 years was some of I think the most devoted people in this state to improving health care has been, I guess, a highlight of my life. But, after 40 years of being involved in health care, and really, I guess the most intimidating thing was when I got appointed chairman of public health. There was doctors, there was nurses, nurse practitioners, not nurse practitioners, but physical therapists. And I just wondered, how am I going to handle this? Well, I knew for sure that there was a lot more knowledge there than I had, but I knew there could nobody there outwork me. During the legislative session, I was always the first person in the Capitol. I actually made coffee for the porters a lot of days. But as I said, I have a lot of support, and as I look around here, people like Dr. Lampton and some of the others, they let me learn. And as I said, I guess that the highlight of my career is being able to serve with some of you people. And I really appreciate what y'all do to try to improve the health care of the people of the state of Mississippi. Thank y'all.
There's no better example over the last 40 years of a public servant than Bobby Moody. I think the word he used was devotion, but he's been extraordinary, selfless, and competent in everything he did. And competence is often unappreciated or underappreciated in politics. You know, the two things about being a public servant is to be a servant and to do it in a competent fashion. And Bobby has always done that. Washington always talked about, and our founding fathers talked about, we should be like Cincinnatus, who left his plow and who was a farmer, and he came and did his period of public service to help his good and to help his country, and then he returned to his plow. And his devotion was to not necessarily to the political power, but to doing a good job and making his community better. And that's what Mr. Moody has done. So thank you, Mr. Moody, for your great work. I'd also like to hear from another public servant who is extraordinary, Chairman Creekmore. Thank you for being here, and we appreciate your service to our state and you serving in Mr. Moody's spirit of public service and selflessness.
Well, thank you. I appreciate the invitation, and I always enjoy, and I know I'm big shoes to fill, so appreciate the kind words and service, and I just hope I can help y'all any way I can.
Thank you for being here. Dr. Edney, do you have anything to say? I know before we approve the minutes.
We can't thank Mr. Moody enough for his service and support of public health. I'm grateful for his support of me as a fledgling state health officer, and he's been an extremely important member of this board for a long time. Very, very grateful for his service, and very grateful to both of our public health chairs who have demonstrated their friendship to public health and to this agency and the work of this agency in and out of session. So their relationship goes more than just the first 3 months of the year, every year. I'm very, very grateful for their support.
And I just want us to, Mr. Moody has been an excellent example of what this board should be about, devotion to the best interests of the state. And so the rest of us should carry on his spirit. And he's not leaving us yet. We're going to, hopefully, we may try to keep you here in July longer, but we'll see.
I'm so glad that was not what his talk was about, but it was about leaders. All of us thought that's what was coming. So thank you for staying, buddy.
He actually would like to leave us. You know, he's done his period.
He's wanted to lead us for a long time. We won't
But until the governor appoints somebody, the members serve in their capacity and continue to serve.
As I told Dr. Eddie yesterday, I think I've aged out.
Well, yeah, my term is up as well, but I'm not going to speak because I haven't earned that. It's a different level of service over the years, but absolutely, thank you, Bobby, for all you're doing.
All right. First item on the agenda is approval of the minutes from January. Has our board had time to review them, and if they have, are there any corrections? If not, is there a motion to approve? So there's a motion, there's a second. All in favor say aye. Any opposed? All right. Dr. Edney, it is time for your report.
Thank you, Mr. Chairman. Thank you, board members. A lot to report out to you, but thankfully we see the agenda is not heavy with regulatory action today. But first off, I'd like to recognize the fact that this is Public Health Week in the United States, and we want to thank you for your service to public health, serving on this board. And this board's history goes back to 1877 and has been the guiding force of public health since the first days in 1877. And we're grateful for your service and your help to guide us through the public health agenda. Very grateful to the workforce, grateful for all of our leaders that are here this morning, the workforce that is zooming in. We can never voice our gratitude enough for all that serve the people of Mississippi through promoting and advancing the health, well-being, and safety of everyone in Mississippi, and that goes to all of our community partners. There are about 2,000 of us working as part of the state's public health workforce, but then there are thousands more out there with all of our academic partners, nonprofit, private sector partners, community partners across the state. I suspect there are over 5,000 people working in public health across the state today in various capacities. I would, as we move into some of our report items, I want to begin, as I like to do, recognizing excellence within the agency, and I have 3 of our programs with their leaders here today to recognize. And Judy, Chris, where'd Judy go?
Judy slipped out and said that she would participate virtually. She didn't. She wanted to make sure there were chairs for everyone.
And
in typical Judy fashion.
Typical Judy fashion. Well, Judy Mulder is our state registrar. That is another responsibility of the Board of Health. And the registrar is that state official over the vital records, especially the death certificates and birth certificates. And Judy has done an amazing job, has had a really stellar career here at the Department of Health, and will be retiring in June. And Judy cannot be replaced, but we do have succession plans that we'll be working with you on. But I wanted to recognize Judy with her retirement, but also the fact that we have just completed our on-site visit with FAB for vital records. And so, Dorothy, how many states have vital records accreditation?
We would be the 5th.
So right now, only 4 states in the country have an accredited vital records program. We will be number 5 if we receive accreditation, but by all indications, they did extremely well with the site visit. And this is obviously not mandatory, it is optional, but it's just another sign of excellence. You remember that we received reaccreditation from FAB, accrediting our public health work as an agency, but this was another item of excellence that our vital records program is receiving. I did place before you, as we're recognizing Judy, this report right here that relates to the death certificates, but also points out the birth certificates. And we'll be sending a copy of this to the public health members of both the Senate and the House. We did have questions about, why are death certificates delayed at times? Well, I can tell you it's not Judy and Judy's team's fault. When it comes to birth certificates, Dorothy, we lead the nation. We're number 2 in the nation with how quickly we're able to generate birth certificates for our newborns and their families. And we're in the 30s when it comes to death certificates, but that relates to us having an elected state coroner system. And those of us who've had to sign death certificates over the course of our practices know there are lots of steps before it ever gets to Judy and her team. Over 9% of death certificates are issued within 5 days, and of the other 10%, there's something in the chain that holds it up, and we've got that information there for you. But with the system that we have, there's not much else we can do to expedite that 10%. Oftentimes, it may be coroners needing more information before they sign the certificates. It may be funeral homes, in the chain. Sometimes it's toxicology with overdoses. It can be a year before a death certificate can be issued. But I just want to reassure the board members, that the vital records team is doing a great job, not only with birth certificates, but death certificates as well. And we will continue to strive for excellence there. And and Mr. Chairman, we're educating our members in public health at the Capitol regarding that. So I want to thank Judy. There you, Judy, come up here. Get up here. So, been bragging on you.
I heard.
Judy is a great example of public service and public health. She knows one of my favorite places is the vault.
Mine too.
That's where all the famous birth certificates and death certificates are, and we have Board of Health minutes going back into the 1800s. That's a temperature-controlled environment, she has custody of some very famous documents over there that we preserve and protect over there. But Judy, we just want to thank you as you move into retirement. Judy did not have to take on FAB accreditation right here at the end of her career, but she did and did it extremely well. So would y'all join me in congratulating Judy? Thank you, Judy.
We might ought to take a board field trip sometime after a board meeting, like at 1 o'clock, and we could schedule a tour.
It is
Maybe in July or October, we could do a field trip to the vault.
It's a very interesting place. We have multiple layers of security for the birth certificate paper because that's like currency, and so we keep the birth certificate, the blank ones, we have to have them specially printed in a special way so they can't be reproduced. And so it's interesting just to watch how that whole process goes and to see, and it's literally a vault. They have to open the vault to get in it, and then you see the birth certificate paper behind more security inside the vault, because if anybody got a hold of a stack of those, you can imagine what damage would be done. So they take security over there very seriously and do a great job.
And they have Elvis Presley.
So you do. You can't see it, but
Elvis Presley's birth
the Presley estate has it under court order. You have to have permission from the estate to see Elvis's birth certificate, but we do have it. So every famous person that's been born in Mississippi since 1912 has a birth certificate over there, and all the famous folks who have died within the state are over there as well. Next, Ron, come forward, please, sir. So we are so proud of Ron and his team's work. Ron, have we brought you to the Board of Health before?
No, sir.
Okay. And I made him come. He didn't want to come. But Ron inherited a program with challenges with radiation health. You may remember that the NRC has been really working with that program, and Ron was brought on, how long ago?
3 years.
And in 3 years has moved us from under heightened scrutiny with the NRC for radiation health monitoring to now they just received their most recent survey. And I had shared with y'all before that we were improving and in better shape. Well, now we're off. I mean, they had a stellar review and really just, another example of excellence within the agency. Brian and his team have done a great job in a short amount of time. It's his team, if you remember last legislative session, Chairman Creekmore, we had to ask for the extra rate, the bump in the fees for radiation health. It was so Ron and his team could do the work that they needed to do, and y'all allowed the Board of Health to adjust those fees. And now they are doing a great job keeping the people of Mississippi safe. Y'all recently had the Grand Gulf exercises, I believe. They have to monitor the Tatum Salt Dome site, the Salmon site where the nuclear detonations occurred in Lamar County. They have to monitor all that. Plus, those of us in healthcare, they handle healthcare radiation monitoring. So Brian and his team do a great job, just had an outstanding review from the NRC, and I don't think it could have gone any better. Congratulations, my friend. So proud. Proud to have you on the team, my friend.
Thank you, Doctor.
Mr. Rogers, thank you for coming today. We're glad you'll have to come back. Not just one time.
He may resign if you.
We won't make you come back. Just stay here with us.
Thank you. And Julio, if you would come forward. Julio Cespedes is within Dr. Dodson's Center for Public Health Transformation. Julio oversees our telehealth program. And Julio, I'm not reading this. Julio didn't write this, but the staff preparing the blurb of all his accomplishments are a page long. What I wanted to recognize is the fact that Julio has been invited, is it 3 or 4 now, that national invitations to present the work that he and the center is doing on the national stage. And he's, roping me into an event in New Orleans where, he and I will be serving on a panel related to his work and with telehealth and how we're applying telehealth in public health and leveraging it for the benefit of public health. But he is generating academic work in respected journals and then being invited to speak multiple times at the national level. I just wanted y'all to have a taste of the expertise within the agency and how it's recognized. Some of it gets, pretty nerdy. So pretty specific and stuff that they have to explain to me. Okay, so, but his stuff I understand. But he's just one of many in the agency who are invited to national conferences to speak, and they do so on behalf of the work of this agency. So congratulations, my friend. Real proud.
Yes.
Dr. Jim Barnett came to me in, I think it was the early 90s, about telehealth. I had no earthly idea what he was talking about. But thank goodness, he brought that to our attention and we were able to go ahead and pass legislation that allowed it to move into the state of Mississippi. And I think it has been one of the things that has really increased our ability to provide significant health care in this state.
Especially in rural areas. It makes a huge difference in rural areas.
All right, great. Thank y'all for allowing us to do those recognitions. Next, I want to recognize Dr. Dodson, who is our state epidemiologist, and she's going to give us a brief update on where we are with communicable disease activity and answer any questions. Dr. Dodson?
Well, good morning.
Good morning.
Good morning.
All right, I'm going to give you the quick and dirty on epidemiology. How about that?
That sounds good.
Do I have this slide advance?
Dr. Eddie has the clicker.
For the clicker. And I'm not even married to him and I can't get the remote. All right, so I'm going to start with what's been in the news that you've all been hearing about and probably a little anxious about, and that's the measles update. The good news is we've not had any cases in Mississippi, so that's we're still very thankful about that. But a little background about measles: it's highly contagious, febrile rash illness, and if you've never seen it before, that means that we did our job with vaccinating people. But it can infect 9 of 10 susceptible people who are in close contact with somebody who has measles. It can cause serious illnesses. 1 in 5 people are hospitalized with it. 1 in 20 will develop pneumonia, and 1 in 1,000 will develop encephalitis. And then 1 to 3 of every 1,000 people will die from measles. And in Texas, they've already had 2 deaths in school-aged children there. The current outbreak, we know that it's due to people who are returning to the U.S. from international trips in places where they do have measles, and they're bringing measles back into the country. And then also there's an expanding outbreak in communities with low vaccination rates in Texas and New Mexico, but those communities also travel because they're a very close-knit and insular community, and they travel back and forth and have been traveling into Mexico and Canada as well. So because it's such an insular community, we suspect that the outbreak is much larger than the 500 people that have been recorded, because that population now is very reticent to talk to public health officials. They're wary of us. They're wary of the government. They can't understand why so much attention has been turned to them, and so they're kind of closing ranks and huddling in. So we believe that outbreak is probably larger than what was stated. The risk assessment for it, though, is that the overall risk of widespread measles is really, really low. And that's due to high childhood vaccination rates with the MMR. The risk among adults is low because you either, one, have lifelong immunity from having had measles once before, particularly if you were born before 1957, or having received the MMR vaccination. And that remains the best protection against measles. And our new HHS director finally said that out loud, so we were very pleased about that. But the even better news in all of this is that Mississippi's vaccination rate is 97.5%. So we're well above the 95% that you need to have community protection. We are ranked third nationwide for vaccination rates. We used to be 1, we're now 3, but we take the 3, and we take our 97.5% very seriously, and we're very proud of that. And as I stated before, we have no cases reported in the state.
And Renee, throwing Dr. Dodson a curveball, I want to share with the board this information that Dorothy's vital records team shared with me. This goes back to 1929 and shows you the deaths from measles through 2023. And you can see the high burden. This is mortality. These aren't total cases. Total cases would be much higher than this. But you see the mortality burden back in the 30s and 40s, still significant in the 50s and 60s. And then you see in the late 60s, it drop off. And that's introduction of the MMR vaccine. And you see the last death we had in Mississippi was 1986. The last case we had was in 2002, and that was a traveler case. And the last endemic case we had, cases we had were in 1992. That was related to travel as well, but it was a Mississippian coming home, and then it caused an outbreak in college and university age. That's back in 1992. We've had no cases whatsoever since 2002. We've had no endemic cases since 1992, which has prompted Dr. Dodson and her team to issue health alert notices to our provider base to remind them what measles looks like. Because physicians younger than myself have never seen measles, have never diagnosed it, unless they've seen it in the developing world. And so we're trying to remind, doctors, think about measles, and reminding them what measles looks like, and keep it on the differential as our vaccination rates are slowly easing down, and we're surrounded. There's outbreak in Tennessee now, is that right?
There is.
And so we're surrounded. We had an outbreak recently in Georgia, the huge outbreak in Texas that's spilled over into Oklahoma and New Mexico. And there's been a lot of travel through Mississippi of cases from Texas to Florida. So, coming across I-20 or I-10 down the coast. So we have to be vigilant. But this just shows the effectiveness of the vaccine, and total numbers would look likewise, and then just peter off to nothing. So we're thankful that we're still not seeing cases, but we're having to be vigilant for it.
Mortality usually occurs in pediatric patients, or?
It can be, we've been seeing it, the 2 in Texas have been in children, no adults yet.
What, they develop a pneumonia, or what usually is the course of the mortality?
You can get the pneumonia, and then, or sometimes encephalitis too. Sometimes you get encephalitis, but pneumonia usually develops into ARDS, and then total cascade that comes with that.
But you mentioned international, I'm sorry, go ahead.
With the 2 states that are higher vaccination rates than us, do they have different rules than our rules? Are they tighter, or what's the difference?
They have laws similar to ours, but they're not under federal order to require exemptions. So West Virginia was always number 2, and West Virginia is being sued. So they're going through the process, but they're in a different, circuit district than we are. And I would remind y'all, I don't know if you noticed that in New York, their circuit court upheld the state's interest in their vaccines. Because New York had a big measles explosion, and they removed religious exemptions and tightened back down. California did likewise with the Disneyland outbreak. They removed their exemptions and tightened down. And so we have two different circuits saying two different things. So I expect the Supreme Court will take it up at some point, and would remind y'all that we never conceded. We complied but did not concede, and we did reserve our rights for further appeal should the Supreme Court make a decision. But a good bit of activity. So West Virginia is number one right now, but they're under a lot of pressure for religious exemptions as well.
And who's number two?
I don't remember.
Okay.
We were number one for a long time.
Yes, sir.
Dr. Davis.
What countries, as far as international travel goes, what are the countries where measles are more prevalent that would place an unvaccinated person at risk?
Did you say, I didn't, CDC in that last one did not name them specifically, but it was just like we kind of scrutinize all international travel.
Remember, you have to, once you fall below 95% population immunity, then the measles becomes endemic again, which we're very close. WHO had ruled us as a country with eradication of measles because we really had at the around 1999, 2000, I think we're pretty close to losing that status. It's becoming endemic in the United States again. But pretty much anywhere in the developing world, in fact, most of our territories in the United States, the Pacific Islands, their vaccination rate's around 50, 60%. When you're down that low, it's endemic. So most places, most areas of the developing world, it's endemic.
And then secondly, pertussis. We've seen an uptick of, well, the whole country has seen an uptick of pertussis since the 1980s. And it is also a highly contagious cough illness lasting more than 2 weeks and can be characterized by that inspiratory whoop, which gives it this common name, whooping cough. Doctors are saying more and more of that. We're seeing it in the pediatric population. Our current outbreak here in Mississippi is that we've had an expanding outbreak in communities that had low vaccination coverage up in North Mississippi. We have reported 32 cases for this year. 32 may not seem like a very large number to you now, but overall for the entire year last year, we had 49, and we're just into the middle of April of this year, and we're already at 32. And we've seen outbreaks in communities. Like I said, cases are increasing across the U.S. and has been doing so since 1980. We had a dip during the COVID years because we were doing mitigation procedures then that probably decreased the spread of it. And the reason for these outbreaks is that we think the organism itself may have changed, and then there may be waning immunity to some of the previous vaccines. And therefore, sometimes for certain individuals, boosters are recommended. The risk assessment of widespread pertussis is low due to our vaccination rate again at 97.5%. And the vaccine it still remains the best protection against pertussis. But I want to take a moment here of personal privilege and brag on our epi staff on the ground, because unlike there are similarities in our pertussis outbreak and the measles outbreak in Texas in that they're in very insular communities where the vaccination rate is low. However, we have enjoyed better cooperation from those groups and from their elders because our individuals on the ground actually have relationships with those communities, and they leverage those relationships, and they went in and were seen as a trusted voice there. We met them where they were. In cases where they were not able to get the prophylactic medication or the treatment for the disease, we provided it to them at no cost. We went into the homes, We tested people, they trusted our nurse, and then they would then tell her about other people. Like, this family has sick people here, because they trusted us, and we didn't out them. That was one of the problems with the Texas outbreak. That community was outed, and it became a national sensation, and they felt everyone was turning on them and looking at them. But here we used relationships, and it was all about the people and getting them to trust us. And our nurse on the ground there, Dina Thompson, did an excellent job of going into the community and treating the individuals who needed to be treated. And they in turn helped us identify others who needed to be treated. So we're very proud of our team. I think that's it.
And thank you, great job. And I am very proud of the response. We've always had cases of pertussis that would pop up. This is a small outbreak, but outbreaks are obviously more concerning, but they did a great job containing it. But this also points out the importance of using the DPT booster, not just giving tetanus boosters, but going ahead and doing DPT to get diphtheria, pertussis, immunity up. And specifically, folks like me with grandbabies, grandparents with newborns, making sure that we're boosted and up to date. And I call the DPT booster the granddaddy shot. If you're having your first grandchild, you need to have your DPT booster done to protect that infant, because your pertussis immunity may be waning. All right, thank you.
Can I ask just a real quick question? These insular communities that were unvaccinated, were they unvaccinated because of religious convictions? Okay.
Yes, and I think it's going to be important that a lot of lessons learned from the Texas outbreak that is still raging, and by watching the behavior of the index population and learning really how to be careful not to, because it's one thing to be vaccine hesitant or resistant, it's another thing to be public health response resistant and refusing to quarantine, refusing to limit travel, refusing testing. So there are a lot of cases in Texas that aren't being tested because people are refusing testing. So we've all been studying that outbreak, and applying it certainly to the pertussis work that's going to be ongoing. This will continue, but should measles be an issue, just learning how to respond in a way to protect the populations that are impacted and those around them, and just make sure we can contain these outbreaks as they occur. Okay. Any questions? All right, Logan, you'll come forward. We'll go through a report of the legislative session. I would just introduce Logan's remarks by just saying I think we have had a very successful legislative session. I had to say thus far because we don't have a budget yet, but it's coming. And thus far, our appropriation discussions have all been very favorable. I don't have a lot of heartburn at this point, but I'm real proud to notify the board. We're going to walk you through it, but we went 8 for 8 with the health department legislation, and we'll be walking through those 8 bills with you, but then also the ancillary bills that impact us. The major assignments that look like were coming our way did not make it, so and actually I'm kind of breathing a sigh of relief right now because of the challenges on our plate right now, but we still have plenty to do. So I'm going to ask Logan to walk us through, and I also want to just absolutely thank Chairman Creekmore and Chairman Bryan for being great friends and partners through the session and working with us with our legislative agenda and being extremely supportive. And absolutely, we could not have achieved what we did without their support. And Logan did a phenomenal job working at the Capitol. He's still having to work until we get the budget done. But Logan did an extremely good job. I'm very, very proud of his good work. So Logan,
Thank you, Dr.
walk us through.
Thank you, sir. All right. First, I'll walk us through the 8 board legislative agenda items that Dr. Eddie alluded to. First one is the yearly controlled substance law. I didn't put every chemical compound on here, but there were 16 substances that were scheduled 1 this year on the controlled substance law. So, the one pending item, this is the yearly requested support we've done the past couple of years for the Underwood project and the revolving loan fund. The loan fund has been in our state appropriation bill for the last couple of years, and that is one item that is pending with the special session. We requested 8.3 million this year, and as Dr. Edney said, we had good conversation so far, but we'll have to see how the special session plays out. The second is the Underwood and Thompson Lab. Last year, we received 4 million, and this year in House Bill 1131, which was sent to the governor last night, actually, is another 4 million for that project. And if you want to speak, I put some pictures, this is Underwood, so it wouldn't let me inside.
No, this is great. I was asked by one of y'all this morning, what's going on in the courtyard? Okay. So here's the hole in the ground. But this is the work that we've been sharing with y'all the last 3 years, and there will be new building, and where you see that footprint, and then a renovation of all the old building that we're currently, that we have some space sharing the public health lab we can't even use right now, the old lab. So, but that's gonna be brought back online. So all of our Underwood building will be back online for use, is that right?
Correct. What they're building
Plus
right
the
now
new-
is the pharmacy warehouse with our ARPA funds, and then they'll
Yeah.
renovate the old lab and then go, which is that building you see right there, and then go into our Underwood building.
And if you've never been to where our current public health pharmacy is, please don't go. You know, but it will be brought from its current location that's difficult to secure, it's in a bad location, building's worn out. All of that will be brought on campus under the new construction, and we'll have all that square footage back available for us. The old public health lab is actually kind of historic for us. The original state health officers, Dr. Underwood's office, Dr. Cobb's office, were offices
They're in the
and the Underwood, which Sharon's office is now. We'll be preserving that, but that we'll have all that square footage back online.
And while we're showing pictures, this is, if you remember last year, we were tasked with the EMS memorial, and I just wanted to post the pictures of, you can explain everything that's been going on. It looks like there's a lot of landscaping originally, but I'll let you.
Yeah. That is the pad for the memorial itself, but we're waiting, we had enough money left to install an irrigation system to protect the landscaping that's going in. And Chairman Creekmore is the expert on landscaping, but I'm told the special plants that it had to be ordered, and we're waiting for those to come in. They've cleared out all the old stuff. They have the footprint in place. After it's over with, the front lawn of our campus will have the memorial and all the new landscaping, and will be a beautiful area for families to come and visit. We should be finished on time by July, and we are scheduling dedication service once we get into early fall and the weather starts to cool off, and the governor has agreed to come and provide the keynote for the dedication service. So I think by July, you're going to see most of the work done when you're back for the Board of Health meeting.
All right, the next bill, we received a public health lab exemption for the state health lab. This will exempt contracts and service for servicing specialized equipment and software used by the public health laboratory. And this will facilitate quicker and more efficient maintenance. And we estimate that the savings will be approximately $500,000.
Yeah, we were the last state lab not to have it, so we were grateful to be allowed to have the same exemption that State Crime Lab and other labs have. It keeps us from having to have sole source procurement for service contracts on highly specialized equipment, and it's only for that type of procurement. It's not general lab procurement, but it's highly technical, specialized equipment where we don't have a lot of options. It allows us to procure it much more quickly, get more favorable service contracts in place, and not be on the sole source list of procurement for the state. So we're very grateful. It'll save us about $500,000 a year.
The next bill, this allows for a water analysis fee adjustment for our water quality analysis, and essentially, we'll be able to have a one-time fee adjustment, and the adjustment is that the fee cap will not exceed $3.75 per connection or $50,000 per system, whichever is less, and we estimate this will save around $1 million a year.
And this will help cover the water testing at the public health lab for our water systems. We've been using part of the SRF program account that is not going to be available going forward, and this was us getting ready for that. There's probably going to be about a $2 million deficit for the lab, that this will cover $1 million of it, and we agreed, working with legislative leadership, that we would do it in stages. We won't have any deficits probably for another 3 or 4 years with this fee adjustment, and we'll go back probably in 3 years or so and ask our friends to help us again, but this will cut our losses in half.
Is this a fee that's just billed to every water system, they pay it annually? Or is it, I mean, how is that collected?
Yeah, and I in terms of how it's, because I believe, Chris, is it we're paid annually from the water systems?
They pay it annually, and probably what will happen is they'll pass those fees on to their customers, so
Right.
you'll see a small increase.
And we calculated, Mr. Berry, it's going to be less than 10 cents per month per customer to save us having to use $1 million of state general fund money.
I mean, it's gonna be, work out for the 50,000 is gonna kick in, I would think.
And but the cap now is like 45,000 or something. The cap went up a little bit, the per connection fee is going up more, but again, it's about 10 cents per month per water bill across the state. And we still will have $1 million deficit in 3 or 4 years, but we'll have time to work on that. This positions us into a more healthy situation. And just to remind y'all, a big part of my goal for financial sustainability is getting our fees healthy, just to cover the expense of our regulatory work as much as we can. And this was one of our fees that we needed to adjust, that the legislature supported us in doing.
Doc, I'll let you take this slide.
And our community health worker bill was successful, a large part with Chairman Bryan and Chairman Creekmore advocating for us, and also working with the Division of Medicaid. We have, ahead of time, kind of been looking at options of other states who have been moving in this direction. For us, community health workers are going to be already are an important part of our workforce, but will be a way for us to make the county health departments more effective and more connected to the communities, and control our overhead as well, because they're lower cost employees. And so the bill did recognize them formally as healthcare professionals. It does require us to set their core competencies and certification and regulatory oversight. And then the Division of Medicaid will be working with us to provide reimbursement for certain services that they do, as other states are doing, and also as we're already doing in Mississippi in the mental health and substance abuse space with peer support recovery specialists. So it would basically be an extension of that program. And we also see that the Division of Medicaid is looking at assigning doulas, which are community health workers in the perinatal space, assigning doulas to the high-risk Medicaid moms to improve outcomes. So it's just kind of bringing the whole package together. But Sandy Bradshaw and I have been working together on how this needs to look to make sure that, we're actually looking at probably doing a demonstration project between us and the Division of Medicaid and being very careful with budget impacts and, what's the best way to do it. And the Oklahoma did a state plan amendment doing that exact thing with the Department of Health and their Medicaid division working together for the demonstration projects. We're likely to follow their example, but Health and Medicaid will be working together moving forward with this.
The next bill we have is related to vital records. This amendment will allow us to use the fees collected from birth, death, and marriage records to be able to use for public health programs focused on maternal, infant, and child health. And Doc, I don't know if you wanted to add anything. That's a simple explanation.
Yeah, I think I've shared with y'all before, this is a state special fund that in a 1930s era statute restricts our ability to spend money in the special fund to the production of birth certificates. Can't even use it in vital records, it has to be in the production of birth certificates. So it's been extremely hard to spend and accumulated more than it needed to and not doing anyone any good. We asked to have that fund unlocked, but we're happy to do it in a very specific way. So it still is related to the issue of births, but in looking at maternal child health issues and then expanding it to all the vital records. So if we need more investment in generating death certificates, we can now pivot those resources there as well. So this money is being unlocked is going to allow us to pivot in some areas where I think some federal cuts are coming, and because they allowed us to have a very, very low maintenance ask with our budget this year. And I know Chairman Bryan and Chairman Creekmore were very, very supportive of this. Our appropriators were very supportive, and everybody understood, allow us the opportunity to use this money thoughtfully, but in a way that helps moms and babies in Mississippi.
Doc, I know you're excited about this one. This is the Mississippi Public Health Trust Fund.
I sure am. I told Logan I had budgeted us 3 years to get this done. And lo and behold, because of our good friends, we got it this session. And I'm extremely proud. This allows the Treasury to set up a special fund that will allow us to bring in different revenue streams. It still allows us to look at appropriations from the legislature into the special fund, but also private donations, private grants, opportunities that really we don't have. And before you poo-poo the issue of private donations coming to the public health, we have already had inquiries about donating to the trust. A lot of excitement in the public health world. First thing we will do is generate a public health car tag, proceeds going into the trust. We'll be talking to the legislature about perhaps, and have actually had them talking to us about using some of the cannabis excise tax revenue to look at supporting this. We'll be building this out over the next few years, but my goal is that this will be more of an endowment for public health, and once the corpus is built, then the proceeds of the investments coming off. Right now, we're limited to 3 to 7% from the total assets annually. It'll take a while for it to grow, but once it's there, it's another diversified revenue stream for public health. And with some of the challenges that we'll talk about today, this was really the reason I was envisioning the trust, was so that when there are budget challenges at the state or federal level or the local level with counties, that we do have some sustainable funding that is not impacted by budgets. So very, very proud, very, very grateful for our champions shepherding this through. You know, and I would tell you that we weren't, not only were we 8 for 8, but most of our bills were double referred, both chambers. But that's kind of the, so we had to get everything out, you know, twice every time. But that was, and it wasn't directed at us, that was pretty much everybody. Had a lot of double referrals this year, but we were able to work through that. So I'm very, very, very proud of this.
Yeah, I would echo your comments about the opportunity for private donations. You know, there are plenty of well-endowed charitable trusts that have that as part of the mission of the trust, is public health. The School of Public Health at Johns Hopkins is named after, you know, it's the Bloomberg School of Public Health because of an enormous endowment. I realize that's a university and that's a school of public health, but you know, if the goal of a charitable trust is to impact public health, this is, you know, I think a tremendous opportunity with a comparatively low number of dollars to pretty profoundly impact the health of a group of people, you know, right here in Mississippi. So I agree with you wholeheartedly about the importance of pursuing private dollars for this.
Yes, sir.
For this trust fund. It's wonderful, wonderful piece of legislation. And thanks to our advocates down at the Capitol for, you know, double referred in both chambers that's a big hill to climb over. And so, yeah, much gratitude from us to you guys.
But we never had trouble getting out of public health in either chamber. And I want to, you know, Chairman Bryan, wasn't it the Public Health Trust bill? The chairman called a meeting of public health just for our bill to get it out on the deadline time, which, you know, he did not have to do. And we were very, very grateful. We could not have gotten our agenda through without both Chairman Creekmore and Brian's support.
We should probably let them eat lunch with us today or something. Gratitude.
But the Board of Health has a significant role in
You do.
this.
Please notice that what we will do is, you know, as there's enough there to do something with, that then we will bring, it's not to support the agency, it's to support the work. And we will bring projects to the Board of Health for your consideration and your approval. So you will be serving as the board, the endowment board. And then, of course, we'll report to our appropriators what we're doing. But, you know, no one, I can't go out and ask for donations to the State Department of Health. I can go out and ask for this. This will be part of my estate.
And our strategic planning as a board will focus on the essential needs in healthcare in Mississippi. And this may allow us to focus on some areas that are neglected, that need focus, and even pilot studies. This is an exciting and wonderful thing.
Go back, Dr. Whitney, and talk about the cannabis, like part of the cannabis excess. We can get part of that. I remember us talking about that last time.
Yes, ma'am. Depending on what appropriations would do, they would have to be appropriated into the fund. But last year, the program generated $9 million more in through fines, fees, and the sales tax and the excise tax. It was $9 million more than the cannabis program's appropriation or Department of Revenue's appropriation for their cannabis work. So the state made a $9 million profit off cannabis, and it's just starting.
It's everywhere.
It's just,
Like, I think we should get, if it's for medical use, I hope that they recognize that the public health should get some of that.
so I've
from the
had,
appropriations committee.
What about the expenses associated with the investigations? I mean, I know that there was, I'm not trying to get it off the.
Don't they?
we didn't get that this time, but we will continue working for that.
So the almost $1 million we've spent, I think, on the lab problems and some of the other investigations that were very, very costly. Are we just eating that right now?
The program does, but the state does not, because then, you know.
So we get an appropriation for the program, so.
Correct.
So our
And then the
expense.
state gets it on the fine side.
Right.
So we charged, I mean, there was a large fee fine burden imposed because of that investigation. The fines are, now that the program's maturing, fines are going up, both from us and revenue. But, you know, and Laura, that's the key piece. And Logan, we have got to
So I
remember.
should make sure I'm saying this the right way. We spend the money to investigate.
Correct.
The cost for that is not necessarily covered by our appropriations. And the fine revenue that is generated doesn't come to us to pay for that. It goes to the general
Goes
fund.
to the general fund.
So well, I just want to make sure that we're not really, when we talk about the expenses of the cannabis program, we should be measuring it based upon what the appropriation is vis-a-vis the revenue to the state of cannabis. The actual expenses associated with the cannabis program are higher. Am I saying that correctly?
Well, it thus far has not been. Even with that investigation burden, we were able to manage it through the appropriation. So no agency resources had to go in, and we didn't have a deficit to cover. But we do need to get that legislation to allow us to charge investigation costs as other regulatory agencies are able to do, so that we don't have that exposure. So that's an extremely important point.
Yeah, because from what I'm understanding, we pay for the investigation, and then the results of the investigation, if there are fines that are incurred to the providers, the root downs, or whoever of the world, they have to pay the fines, but that money goes to the state.
It does.
Okay.
And
I'm understanding now.
like many of the regulatory agencies are able, if there is, if their investigations sustain the allegation, are able to charge the investigatory cost to the entity. And right now, we're not able to do that. But we will continue to work to have that permission. Any other?
Is that all on the legislative stuff? Is that two other things?
A couple of extra things. And no pressure, but we will be looking at license plates very soon for everybody pulling up into the parking garage. Make sure you have a public health license plate. All right, next.
And this is the final agenda item from the board. This is more of a technical bill. This is the COVID-19 ICU expanded capacity program from a few years back. We realized there needed to be a technical change on the date to push out the reimbursements to 2 hospitals. And my understanding, these are the 2 hospitals, Gilmore Amory and Singing River. And Dr. Edney, correct me if I'm wrong, but those are in processing right now.
They are. And as soon as the ARPA compliance is complete on the invoices we have, we'll be sending those checks out. That will close this program. Okay.
And these are
assignments to us.
the first one is the dietitian licensure compact. This will allow dietitians to work across state lines via compact privilege. And it seeks to streamline licensure processes, reduce administrative burdens on both the dietitians and member states, while enhancing the state's ability to protect public health and safety through uniform requirements. I didn't know if you wanted to add.
No. Okay, that's good.
Any questions? Okay. Next one is parchment inspections. This will direct us to conduct an annual structure and environmental inspection of the infirmary at the state penitentiary beginning on July 1. We will assess the structural integrity, environmental conditions, and the related health and safety factors. And then, of course, we'll have to provide a report to the governor's office and the commissioner of corrections.
We already do safety inspection, the parchment. This will loop the infirmary in as a healthcare facility.
The next is the Burn Care Fund. This bill will mandate that all of the monies will be equally divided amongst the burn centers. And that's essentially the purpose of the bill. Doc, if you want to.
Yeah, the previous language had all the burn component going to UMC. Now we have 2 designated burn centers, one at UMC and one at Baptist here in Jackson. And this just changes that language so that the burn fund money goes to any of the designated. So if we wind up having 3, 4, or 5, which I doubt, but if there were, then it would be split among all the ones who are designated. It also, Look at it, the language changed where we can now reimburse the out-of-state burn centers that are serving.
I believe so. I think
Mississippi.
that was going to be an addition.
Okay, but mainly for our 2 in-state burn centers. That's usually about $1 million a year that now would be split.
Is there any more detail with that? Are there performance measures? Are there other criteria as far as how this is?
They just have to maintain their designation as State Department of Health's designation as a burn center for Mississippi.
If one treats more patients than another, should they be getting more money? Is that, or how does it, is it just divided down the middle, or is it based on care of patients?
And I was thinking as much as anything, acuity of patients, one hospital over another. I mean, you know, I can see a variety of reasons where there might be some legitimate reasons to have non-equitable distribution of funds, depending. I mean, I just didn't know if there were any criteria assisting with that decision.
It basically was to change the language that was UMC specific to.
And that makes sense. That makes sense. I just think there's probably more detail there that we're going
And
to.
it was gonna, they initially were adding Baptist language, and we asked them just to change it to designated burn centers, because that's gonna change over time. And if one of them loses their designation, then they lose access to burn fund.
So what is the burn care fund?
It's part of the trauma fund, it's the specific burn component.
Yeah, several years ago, we carved out a section out of the Mississippi Trauma Trust Fund to designate it for burns. We got in a pretty desperate situation with burn care in this state, as you recall, and that was to kind of help fund some of that.
Like uncompensated
Yes.
care and that kind of thing?
Yes, and there's a formula, for the trauma side, there's a formula for hospitals to be reimbursed. They get 2 disbursements a year. For the burn fund, it's $1 million, and before it was just $1 million going to UMC, and now it'll be split. Okay.
This is a bill about licensing music therapists. I was going to let you.
And no conflict. My wife is a music therapist, but hadn't practiced since 1991, so. But it actually, I know a lot about music therapy, and they, you know, so I think licensure is long past due. It sends it to us with a 5-member committee, and you see the details there, so it'll be just part of our regulatory action that music therapy services will have to be performed by licensed music therapists. I think that's good legislation. In the same bill, there was a cancer care task force that was formed that myself or appointee will be a member of. So I tell you, it's very reassuring that not only did we not have any anti-public health legislation directed at us, no anti-vaccine legislation directed at us, but we were being asked to serve, and it just to me it shows that we're being trusted in our work and in our opinions. So we're happy to do this for the legislature.
Okay. The next bill is related to Medical Cannabis Act revisions. 3 main ones I pulled out was it will redefine the Mississippi Medical Cannabis Equivalency Unit to equate 1 unit with 1 gram of total THC in concentrates or infused products for consistent medical cannabis dosing. The second item was to enable telemedicine certifications, and the third was to require cannabis establishments to applicants to secure a state license before they can seek local zoning or permits, which should streamline the approval process.
The telemedicine, is it limited still to Mississippi doctors who are registered with the program?
Yes, and they have to be certified as bedbound by a separate doctor than the one who's seeing them for the card.
You anticipated my next question, so thank you.
And next item is the Mississippi Opioid Settlement Advisory Council. And this is a council set up to help guide the allocation of the settlement funds that will be coming our way. Mainly,
Our way in terms of the state of Mississippi.
Yeah. State health officer or designee will be a member of the board, and the state health officer will also have 2 appointing non-voting members, and that'll be a member from the community health centers, and a member representing the private sector substance abuse treatment facilities.
Chairman Cookmore, I think that's very, very good legislation, sir. I know that was important to you.
Yes. Okay. All right. And Doc, I'll let you, this is the final slide.
So here's where we are with CON. The governor has it on his desk at this point. And you know, we have the 2 principals here with us. But a big issue was getting the thresholds doubled, which I think is going to be extremely helpful. And then, Chairman, y'all just interject as you need to. My understanding, though, that wanting us to study and report further in terms of exempting the small hospitals, specifically in dialysis and with psychiatric funds, which we've been doing and we'll be happy to do in more detail. The third bullet point actually would solve a big problem for us, because part of the CON statutes require CON holders to provide a minimum standard of uncompensated care. And the current thought for us to look at is having, especially in adult psychiatric units that are detaching from ERs, it's giving them the option of meeting the uninsured rate that's set for the region, or to do a pay or play model where we're not going to treat patients for free, but we'll pay, just like the trauma fund, we'll pay into the system, and then that be used for uncompensated care. But we're to Chairman Bryan, that is y'all were asking us to study that. Is that correct? If the governor signs it? Okay. Yes, sir.
2 questions. One, does the statute say small hospitals? What do you mean by small?
That's why we have a state department now.
So the,
And I'm not being flip, I'm serious. I don't know how to define small, and that's one of the small hospitals, how you define them is part of the issue.
So we should explore that definition.
I mean, I'm also kind of curious, like, why the focus on small versus large versus geography versus underserved versus, like, what was the thinking on the small?
Am I supposed to pontificate?
I mean, I think it'd be helpful for y'all to pontificate a little bit so we can understand.
Well, the story on all of these, frankly, is that the House was, I think, more enthusiastic about moving ahead, and I was more cautious, which is not to say that either of us are right or wrong. It's just sort of where we are. And so I think that, Sam can speak for himself, but I think we'd like to do something next year. But again, I continue to be cautious. There was a suggestion made that if hospitals, small hospitals, however you define it, could provide dialysis, that would be a convenience to their patients, that would provide them with a source of revenue, and in particular that it would prevent transfers for patients who otherwise could be treated in those facilities. During the course of this, I met a lot of urologists that I'd never met before. But again, speaking for myself, it seems to be the most compelling argument, and the thing that may be most easily addressed is for a hospital, and I say small intentionally. I don't know whether we need to focus on rural hospitals. I don't know that we need to focus on hospitals of a certain size, but the hospitals that we're trying to keep open, the hospitals that are struggling, the hospitals that mean a lot to the community in the sense that there is an actual functioning hospital that you can get to and that can handle things. And again, I think the Department of Health can do a better job of defining who it is we're trying to reach than I can off the top of my head. But the compelling argument that I heard was about the transfers. And I think there is an analogy with anesthesia in that, as a practical matter, larger hospitals have anesthesiologists on staff. Smaller hospitals don't. They have a surgeon who, to some extent, fulfills that role, but when you're balancing everything, better to have a hospital with a surgeon who can take responsibility for the anesthesia with a trained nurse than to do without any service at all. And so there may be similar circumstances where some type of dialysis on a short-term basis might be both financially possible and might be also medically acceptable. If it would, at the end of the day, keep a patient in a small hospital, and I can just tell you, I think we all know this, but don't think about it, it means a great deal to have mama in the hospital or mama in the nursing home in the same place where you live, so you can check by and check in on mama during your lunch hour, on the way home, all of that. That counts for something. And so there are all these considerations, and I think the Department of Health is much better at balancing those than I would be, and that's why we passed both the situation with the dialysis and the geriatric psych units. Dialysis is more, I'm sure I'm using the word wrong, technical. There are more considerations in terms of machinery and all with dialysis than with geriatric psych. But again, it ain't my experience, it ain't my area of expertise. All I did was go to the election. You know, supposedly, y'all know what you're doing. And looking at the issue of acute psychiatric care, one of the overwhelming reasons for having the Certificate of Need program, at least in my view, is to make certain that we don't have entities which come in and cherry pick all the paying patients, take the resources that come from that and send it to somebody in New York to add another zero on a salary, and take that revenue away from the hospitals that are, for lack of a better term, seeing everybody that shows up. And I don't know how to solve that problem, but the trauma care fund is some sort of vague analogy, and I don't know what we could do legally. I don't know what is feasible. I'm not so much in favor of making the playing field level as at least making it not quite so tilted. And so I don't know that we need to solve all the problems of the world in order to do something which at least alleviates the problems. And that's my rambling answer to that question. But the bottom line is, to some extent, these things are intentionally vague because we all know what you're doing, I don't. But I think it's also the case, and Sam certainly can speak for himself, but I think that he and I would like to do something in these areas next year, but have the specific expertise of y'all.
Senator, one thing I find particularly appealing about this is the ability that you were referring to of being able to keep mama closer to home also avoids overburdening the larger hospitals that are already at capacity, making it very difficult to get other patients that need to be transferred in that might only be able to receive care at a facility like that. And we deal with that on a daily basis. So that does have a side benefit.
And that spills right over into your particular area of expertise when you talk about patient transport in a state like Mississippi that's geographically large, but has a small population. An ambulance that is transferring someone from a smaller rural hospital to a more urban area to a larger hospital is not available to respond to other calls that ambulance very well might be needed for. And in large counties with small populations and very limited ambulance services, that's a huge deal. Somebody's in a car accident or other accident, that can be the difference between life and death, or they're having chest pain and they call 911. That's the difference between life and death. So there's no question that, I mean, I like the way that this is headed, and I think that there are, in Mississippi, a state with a significant number of end-stage renal disease patients who are on dialysis. If the only reason for transfer from a smaller hospital is the absence of a dialysis unit, which they need 3 days a week to stay alive, it makes a lot of good public health sense to have that capacity local.
And the other thing is, just from a psychiatric standpoint, it is not uncommon for psychiatric patients to be held in an emergency department where they don't have a bed or a capability of taking care of them, sometimes for days without really good psych care, trying to effect a transfer, and it's specifically several states over. I mean, there are a lot of nightmare situations that occur in this state and in every state in the country, actually, every day. So I like the wording of this. Is it gonna make a huge impact? Maybe, maybe not, but there are a lot of other things like this that could potentially be done, but this is a nice step.
A lot of times the psychiatric patients have to be held in jail.
Yeah.
Because there's not a facility or anywhere to take care of them until they can be transported or gotten to the proper.
And you're right, and I don't see that happening as much now as it used to, but it's a determination on the part of healthcare teams to try to prevent that, but sometimes, I do hear it still occurring. But yeah, I mean, we need to work to avoid that, but this will help. This will help with the geriatric population, but then you don't, the non-geriatric population still has an issue, and adolescents are the worst, to be honest with you, as far as trying to find a facility that can take those.
No question. But I mean, one of the big issues we've dealt with since COVID, lesser so now, but still a significant issue, if you've had to go to the emergency department to be seen, is that it's backed up, and this is a contributor to it. If you have a psychiatric patient, they're consuming a room, and then you have people stacked up in the waiting room who can't get back to the area to be seen. This is why, my friends who are emergency department physicians, it's not uncommon for them to go out in the waiting room and sit there in a big crowd of people where you don't have a ton of privacy and begin the process of evaluating a patient, because there's not a place to put them in a normal ER plot or bay.
There's a term for that now, John. It's called waiting room medicine, because it's got to be so common that physicians are having to go out to the waiting rooms and start.
It's a new specialty. Waiting room.
Yeah.
Chairman Creekmore, did you have any comments about this?
A couple. One, we went into this, and I went into it with significant changes for CON based on a lot of y'all's recommendations, which I appreciate. but Senator Brown and I met right at the beginning of sessions. I'm bringing you a CON bill. We both agreed, whatever comes out, we're going to agree to concur, because the longer those code sections remain open, and there were several amendments made from the floor and in committees to try to change things. And so that was our, whatever we get, we're going to get something that we can concur on, not go to conference. So having said that, you know, it made sense to me to form the study committee, although y'all have already done this and sent your recommendations, but have it in the bill, codified, and get an official recommendation from y'all based on this bill, which you have to give it to us by December 1, which would give us time to start the bill process in January. The original CON bill, I had dialysis taken out of CON, and all hospitals could do it, inpatient and outpatient. But this, it did not kick in for 4 years. That was a compromise I made with committee to get it out of committee. Well, with this language, we could still have it, you know, as early as July of next year, if that's the recommendation y'all make. So it just made sense to me that we get this done. And also had the MRI in the House bill, which was taken out, and that's not in the study. However, I still would like y'all's recommendations on that too, if we didn't take that out going forward.
It's,
You know, most facilities like a Jerry site, just approving a Jerry site facility is one thing, but being able to staff it is another thing, your psychiatrist and all your support staff. That's a major challenge.
Yeah, what I've seen are, I call them circuit riding psychiatrists. They cover maybe several facilities, and they're here one day, and a lot of it's done remotely, whether it's through telemedicine or something like that, but they will cover typically 3 or 4, but it allows more facilities to at least have that coverage.
So we'll call a meeting of the CON committee and begin our process and what we need to do. Members of the board that are not members, I really would like some input from y'all as well as we discuss this. So we'll try to meet and then bring it back to the board in July to discuss further, and we'll have a vigorous conversation about this and have something well thought out before they need it.
Mr. Chairman, I would remind the board members, one of your recommendations that came out of the HMA study was supporting the concept of a rural hospital exemption, defining the community that these smaller hospitals are serving, which basically gives them a comprehensive exemption, which would include all of these things. It basically just exempts them from the CON process. And so we'll bring that back for y'all's reconsideration and what evidence we have about that. And I know, you know, as we presented y'all's recommendations, that was well received, but it was like, this may be too much this time. But it actually checks every box up there to have that rural hospital exemption.
And we'll include the MRI issue as well.
And it's with this bill, it's just new issuance.
And these are just legislatively directed CONs. But again, anything else, Logan?
That's it.
Any other questions, Mr. Chairman?
No other questions.
Great. All right, thank you. That is the legislative report. Thank you, Logan.
Yes, sir.
Thank you, Mr. Dillon.
Thank you.
Dr. Edney. It's time for what, the Chief Financial Officer report, Sharon?
Yes, Sharon, come on forward.
tell us about our budget, Sharon.
We don't have a budget for next year yet, so normally this time of the year, I would be going over our legislative appropriation for next year, which we don't have one, but I'm very hopeful we will, and we've never not had one. Very comfortable that what they give us, we'll be able to survive off of. That's really, I don't have a slide or anything, since that's normally what I would go over. You may have some questions about the federal funding, if you need us to address any of those questions you may have. Dr. Edney and I.
Did the federal government take all the money back to solve our Rural Water Association problem?
It solves so many problems. It just made my life less complicated.
I will say with the appropriate, we have our regular appropriation, we have a deficit appropriation we're waiting on, and that is just to help us. We have our legal fees with the city of Jacksonville that we have to pay for. The AG's office sends the bills to us. And then the reappropriation of our ARPA money, just so we can keep spending out the money we've already obligated. They have to keep reappropriating it. So that's really all we have. Anything else?
So we'll know more soon. But right now, we've already worked robustly on our budget requests with appropriation leadership in both chambers, and it's been well received. Most of the message we're receiving is, I think most agencies are looking at level funding. I just made sure, as soon as we got rescission notices, I made sure leadership knew, and we did not have a specific ask related to the rescission issues, and we'll talk about some issues that are personnel related in executive session, but happy to discuss rescission, the federal funds with y'all. But this was not the year to cut us. We had a lot of work to do to get through the federal funding cuts, and also there's still a lot of unknown about further cuts that we're certain are coming with the impact on the CDC. So we will know more about budget very soon.
Okay. Very good.
Thank you, Sharon. And I was just going to wrap my report up. Chris, I thought we had a picture of the mobile unit, but I can't find it.
It's towards the beginning.
Okay,
I saw it.
I want y'all to see the mobile unit in action.
Maybe one.
I saw that.
Let's see. There it is.
There it is.
So,
It sounded like.
we've been talking about the way to leverage our mobile units, and these are agency resources. They're not specific to any program, but certainly whenever we have a significant natural disaster impacting a community, then the units will be deployed. If necessary, if we'd had them with the Sharkey County tornado, we would have deployed as clinical units. But what we have learned is that there's a huge need for replacement of birth certificates. We actually, this time, had death certificate requests, Social Security card replacement requests, which evidently we're able to help with, Dorothy. As I see, we did 30 of those. And then we also provide free DPT booster vaccinations. And oftentimes it's the first responders that are needing that, and volunteers coming in doing chainsaw work and whatnot who get cut, and we're able to give their boosters for free. Then obviously anybody in the county that needs a tetanus booster, we take care of those for free. So the units deployed to Walthall and Jefferson counties, and we're busy, and I think we had 50 vital records requests that we were able to replace, and significant number of tetanus boosters, and also, we plant the flag. The health department is here. Health department's helping. Health department's working in your community. So we will continue doing that. Yes. How many of those? We have 2 right now. 2. And we're also being able to use them as we're renovating county health departments. Actually, they're big enough that we can plug them in to replace a county health department if we have to. We're having to do some technological upgrades for us to be able to do telehealth from them, but they are being well used. Mr. Chairman, that is our report.
Thank you. Excellent report. I did want to officially recognize Chairman O'Brien, who came in after I had recognized Chairman Creekmore, and we just appreciate you.
That's typical for Senate chairman, they're always late.
Chairman Bryan, are there any further comments that you'd like general comments that you'd like to give the board?
Well, that's a dangerous question. But I would say this briefly because we were talking about small hospitals. I'm convinced more and more that we have an incredible and growing issue with rural Mississippi. And when I talk about rural Mississippi, I'm talking about 70 some odd counties. There used to be downtowns with retail. Now there's the internet and Walmart that's gone. There used to be the bank of. There are no more bank ofs. They're all, as Jerry Wilburn once phrased it, all our local banks done been submerged into them Tupelo banks. And, you know, there's no longer a bank of, and in fact, they all have got these made-up names that look like words in the English language, but they're really not. And you have a huge population, a huge problem with depopulation. There are fewer births. There are births taking place in some place like Nashville and Atlanta instead of small towns in Mississippi. All of that is either we'll just throw up our hands and it'll be like 10 counties and the rest of the state can just dry up, or you can start taking specific steps to help rural Mississippi. And one of the examples that I give is simply the federal court in Aberdeen. You can actually have a federal court in Aberdeen. If the federal court is there and they're holding court there, the lawyers will come to where the federal court is. We have the bankruptcy court in Aberdeen, and those operations are absolutely existential for Aberdeen. They would mean something to a larger and more affluent place, but it's different for Aberdeen, and on and on. So without droning on about this endlessly, part of the issue is healthcare in rural Mississippi. Hence the concern about what can we do to keep hospitals open? What can we do to have medical services located at hospitals in rural areas that make sense, but also are part of the package of allowing small communities to continue to exist. So since you
Mr. Chairman,
allowed me the chance to talk, that's what I said.
It's my understanding, I'm told that tariffs will solve all of this.
No. It's abolishing the income tax. That's the solution. As I understand you're short of 100 million, but your legislature is answering that call by abolishing the income tax.
Mr. Moody.
I'm sure Senator Bryan remembers when we were doing the medical scholarships. It was a surprise to me to find out how much of Mississippi was really considered an underserved area. To where if they accepted these scholarships, they agreed to go back to these underserved areas for a certain period of time. It really opened my eyes as to how big a part of Mississippi was considered an underserved medical area.
And Chairman Bryan, we are short 230 million for Hoos County. So, more than 100.
All right.
It's got a lot of zeros.
Tariffs.
Senator Bryan and I were a big part of setting the initial tobacco money aside. And we were never going to violate it. We were going to use just the interest off of it for health care in the state of Mississippi. Well, I happened to be a part of the Legislative Budget Committee about 2 years after that, and income had just fallen out the bottom. And the Speaker made me stand up before the House and present the bill to violate that trust fund. And Marshall Ramsey drew a cartoon of me as a crawfish having to back up. That's on the wall in my office, so it reminds me of it every day.
Last time I'll vote for something I'm against.
Good comments. Back on track. Here we go. The consent agenda. Board regulatory actions. There's 3 items. They're consent agenda, so it's non-controversial, but if anybody wants to extract any of them, the first one, the amendments to regulations governing the Bureau of Emergency Medical Services. These have been vetted by Dr. Carlton and the EMS committee, and he encourages us to support those. Number 2, the amendments to the regulations governing reportable diseases and conditions. These changes were based on request of the state health officer, and the changes are reporting categories and reporting periods. Should be non-controversial. And number 3 is repeal of existing rules governing the Office Against Interpersonal Violence, and this repeal is to improve the efficiency in the program and to expand funds more effectively to community organizations. And these requirements will be put into the request for funding and sub-grant agreements themselves. So the content will not be lost. So these are 3 items. Would anybody like to extract any of them for further discussion, or is there a motion to approve the consent agenda? Second. There's a motion and a second. Any further discussion? All in favor say aye. Aye. Any opposed? All right, we've got the consent agenda done. We're to committee reports. The CON doesn't have a report, but we're going to be holding a meeting probably in the next 4 to 6 weeks. So we'll be working on that. Y'all be looking for us to do that. And we'll begin the work that we have to do on CON. Dr. Cheney, can you talk about the maternal health committee?
Sure. All right, we met in March, and we reviewed a report by Dr. Randy Henderson. He presented an overview of the most recent Mississippi Infant Mortality Review Report and Child Death Report, and then we had a discussion on potential recommendations to reduce infant and child death throughout the state. And he just gave a really good report. There are a couple of things that he pointed out, just in terms of these reports. There is an infant mortality report that's generated annually, but there's no standing committee dedicated to addressing its findings. There is a child death review panel that meets quarterly to examine external causes of death, like drownings, gun accidents, motor vehicle accidents. And based on our discussion, there were 3 recommendations that the subcommittee has for the board in 3 areas. One is development of a standing infant mortality review panel. This would focus specifically on neonatal deaths that occur within the first 28 days of life and death of infants less than 1 year of age. Second recommendation, exploration of gun safety procedures, and then third, full endorsement of presumptive eligibility. I asked my office manager that's over billing in our practice, and she said that our staff has completed the required training and are currently awaiting final implementation guidance from the Division of Medicaid. So that was kind of my understanding of it. But it was another really good meeting, and I'm really looking forward to Dr. Henderson's presentation at the May the 8th, because that's really the next thing is the OB system of care. That's getting that's very exciting.
All right, excellent. Any questions for Dr. Cheney? Is Dr. Anthony, she's not here today. Is she online? Is she on the Zoom? Do we know? We don't know. Dr. Anthony, are you on Zoom?
Can somebody else from the committee get the report?
Yes. Is anybody else from the nominating committee here?
I am.
All right. Mr. Hubbard, would you give the recommendation for the
Leave
nominating?
those that are in office as it is today.
All right, very good. So the nominating committee has made a recommendation to continue the current officers of the board for another year. And we actually are on time this year. The the recommendation is supposed to be in April, and we're going to try to do that from here on out. And the vote occurs now, and the officers would assume in the next meeting. So there's been a motion, and since it comes from a committee, it doesn't need a second to renominate the chairman and the vice chairman. So, all right, all in favor say aye. Aye. Any opposed? All right, very good. We are now to new business. Dr. Edney, there's a proposed respiratory protection fee itemized list. What do we need to do with that?
We need the Board of Health to approve that fee list, and it's just another revenue opportunity for our health protection groups. That fee schedule was included.
Are there any questions about the fee schedule? Is there a motion to approve the fee schedule?
So moved.
Is there a second? Is there any further discussion? All in favor say aye.
Aye.
Any opposed? All right, we're now to old business.
One item, Mr. Chairman, I
Yes.
forget. Sharon, come up, please. Just want to recognize Sharon. This will be Sharon's last board meeting. She is retiring the end of June, and she is moving into a new career field of nursing and doing very well in nursing school, and I hope her doctors are a lot nicer than I am. But she's not given up on nursing so far, but very, very grateful for Sharon's service. How many years?
I've been here for 20, but over 20, 33 with the state.
33 years state service, and looking at a new career in nursing.
Yeah, complete opposite.
Thank you.
Thank
And Lakrita Tribune is our new CFO, and Lakrita has hit the ground running and been extremely helpful. We've been partnering, we've given about 6 months for that transition, which has been very, very helpful. But y'all just want to say thank you publicly to Sharon.
Thank you.
Luke, could I add something? for
Yes,
new
please.
business?
Yes.
I wasn't planning to say this today, but with messages from Senator Bryan and Chairman, in the American College of Cardiology, I'm on the Health Equity Committee. And with that, my family has decided to do a philanthropy thing within the college that affects the health department. We're going to have a rural health fellow. So in the category of you finished your training all the way up through it, being through with internal medicine or whatever, then we're going to put a fellow in the field. It'll be a rural health cardiovascular initiative. And it's going to start with Mississippi. It's going to be for any part of the nation, but it's going to start with Mississippi. It'll be a fellow that'll be with the community health workers potentially. It'll be a fellow that'll do all kind of stuff. Dr. Edney already has plans where he might be able to put someone like that. And we funded that for a 4-year trial to see how this will work for someone to go out in the field in the ways that we've been talking about needing things in the rural area. And this will be all about health equity and with the fellow. So it's the Waits Health Initiative. That's what we established with the college.
That's excellent. Wow.
Got a lot of work for the health department to help us get this done, as well as Tom Dobbs' entity there at the university too. And maybe the cardiovascular program in Corinth and the cardiovascular program in Tupelo. Those are all things that we'll be working with.
But some of the public health trust in the future could do similar projects that could have such an impact. Excellent. Any questions about that? Any other new business? Is there any other old business? We do have executive session to discuss a personnel matter, but I do want to invite Chairman Creekmore and Chairman Bryant to eat with us after the executive session. So if y'all will hang around, you probably could go ahead and hopefully we won't be very long, but we would love to sit with y'all as we have our lunch. So is there, we need to go into executive session, so I need a motion to go into closed session to consider executive session. And it's a personnel matter, so we've got that. It's a personnel matter, so it'll be an appropriate executive session. All right, we're out of executive session, and there are some appendices that board members need to review. Our next, I need to announce what we did in executive session. Action was taken. We approved as state registrar Patricia Garrett Holiday, and
Beginning July 1st.
beginning July 1st. And that was the only action taken in executive session. Our next board meeting dates are July 9th and October 8th. Is there a motion to adjourn? The deed is done. All right, go and get some lunch.